morning. So today we'll be doing critical appraisal of a randomized control trial. So first we look at the clinical question that we want to answer. So we've put a case scenario. This is a 50-year-old male who was a known case of diabetes and hypertension and was admitted last month in view of an acute decompensation heart failure. His echo done showed an ejection fraction of 35%, and he was started on mortality benefit medications, namely beta blockers, ARBs or ACE inhibitors, and mineralocorticoid receptor antagonists. He was also started on diuretics and fluid restriction. Subsequently, he was discharged, but he has come for review only after 90 days, and currently you find that he has persistent symptoms of congestion, namely elevated JVP, basal crepitations, and pedal edema. He says he is compliant to his fluid restriction, but his medicines have not been up-titrated since discharge. So after discharge, he has come to you only after 90 days. So we do a literature review and find this article. The clinical question that we want to answer is rapid up-titration of neurohormonal blockade, mainly the drugs that we mentioned, beta blockers, ARBs and MRAs. Will the rapid up-titration help in better decongestion and outcomes? For this, we looked at this particular article, effects of rapid up-titration of neurohormonal blockade on effective, sustainable decongestion and outcomes. This was part of the strong HF trial. Coming to the first question, is the basic study design valid for a randomized control trial? So here we want to assess a few questions. So is the research question here focused in terms of the population that they studied, in terms of the interventions, the comparison and the outcomes that they measured. So the population that they looked at is people who are between 18 to 85 years, admitted to the hospital with acute heart failure. So how they diagnosed acute heart failure, I will come in the next slide. They were screened during hospital stay, that is in hospital stay, within 72 hours of admission and once hemodynamically stable. The intervention is fast up-titration of neurohormonal blockade. Again, we look at the study protocol, what they mean by fast up-titration in the subsequent slides. The control is usual care, whatever was the standard of care they were following in their hospital. And the outcomes in this particular paper, they looked at successful decongestion. They have defined successful decongestion as absence of, namely, crepitations or pulmonary rays, absence of peripheral edema, and having a JVP less than 6, which they have graded as a congestion score of 0. If we just look at the outcome, we can see that it's quite subjective. A JVP of less than 6, some people may note it as 6 or 5. So the outcomes are not hard outcomes, they are fairly subjective outcomes. They've also looked at changes in orthopnea, body weight, and NT-proBNP levels. Body weight and NT-proBNP levels are objective, but the rest of the outcomes looked here are quite subjective. However, the primary outcome in this trial was a combined endpoint of 180-day first heart failure readmission or all-cause death. This was the study was powered to measure this as the primary outcome, but here we are looking at mainly this outcome, namely successful decongestion. The time is the study protocol initially was as they had determined to study it at 90 days, but eventually they amended it to 180 days as they did not have enough outcomes. So did the study address a clearly focused research question? We can see that the research question was fairly focused. We've looked at the populations, the intervention versus the control, and what outcomes they had planned to study in this trial. Now, how they diagnosed heart failure was essentially dyspnea at rest or pulmonary congestion on X-rays and elevated NT-proBNP levels. We look at the inclusion criteria in a bit. Congestion score, as I had already mentioned, they should not have peripheral edema, they should not have elevated JVP more than 6 centimeters, and they should not have pulmonary crepitations. The absence of all this was taken as successful decongestion. Coming to the inclusion criteria, we've already seen the patient population, 18 to 85 years, and they should have hospital admission within 72 hours and should be hemodynamically stable. But these two criteria were a bit strict, I felt, in terms of the biomarker criteria. They have taken at screening, the patient should have had an NT-proBNP more than 2,500, and at randomization, that is within 2 days prior to discharge, the NT-proBNP should have fallen by more than 10%, but should still be more than 1,500. That was quite a strict criterion for patients to be included. Even if we take the patients admitted in our general ward, we do not routinely do NT-proBNP at admission and prior to discharge to document this. So that criteria was a bit strict. And the fifth criteria, they have also mentioned that the patient should either have no beta blocker and less than half optimal dose of other ACE-ARBs, or have no ACE-ARB with less than half the optimal dose of beta blockers. Again, a bit strict criteria for inclusion in this study. Coming to the exclusion criteria, they have excluded people who required mechanical ventilation in the 24 hours prior to screening, which was again not very good, because patients who present with heart failure in our ward also may require mechanical ventilation in terms of a CPAP or BiPAP. They've also excluded people with myocardial infarction within 3 months. That was also not very good to exclude these patients. Coming to the assignment of participants, were they randomized? So this was a multinational. It was done in 14 countries, namely. It was a multi-center trial. However, it was an open label trial, but it was randomized. Randomization was done in a 1:1 ratio, and they stratified it based on the left ventricular ejection fraction and the country. The allocation was done with a central web-based system, and hence it was concealed. So it was randomized, and allocation was concealed. It was a multi-center trial. Looking at the consort figure, now we want to know whether all participants who entered the study were accounted for at its conclusion. Here, as we mentioned, we are looking at 90-day outcomes. However, the protocol was amended to assess outcomes at 180 days, but here we are looking mainly at 90-day decongestion outcomes. If we look at the consort figure, we can see that 1,641 patients were screened, out of which 1,085 patients were assigned to treatment. From here, we can see that 542 were assigned to the high intensity arm. High intensity arm meaning rapid up-titration of neurohormonal blockade or medications, and 536 were usual care. Coming to the next, 23 died before day 90, while 5 discontinued. In the usual care arm, 30 died before day 90 and 3 discontinued. So we can see at day 90, 514 completed patients were present, while in the usual care arm, 503 were present. Now they have claimed to done intention to treat analysis, which means that they should have, the denominator should have 542 and 536. We will see in the results what exactly they have looked at, but in this paper they have claimed to done intention to treat analysis. The study was stopped early, but that was for the primary outcome which we had mentioned, which was a 180-day heart failure readmission or death. But here we are looking only at 90-day decongestion outcomes. Now, was the study methodologically sound? Here we are looking at blinding, whether the patients were blinded, whether the investigators and the outcome assessors were blinded. So this was an open label study. Again, it was that part of the study is not very good, because the outcomes are also not hard outcomes. We are looking at subjective outcomes, namely presence of crepitations, elevation of JVP. So the open label study was not a great design. The patients and investigators were not blinded. They have not mentioned about the outcome assessors. If they had at least blinded the outcome assessors, we could have the validity of the study would have been a bit more. But here they have mentioned it as an open label study.
Would this have been blinded?
The outcome assessors could have been blinded to which category, and in terms of titration, they could have titrated with placebo medications like that.
Okay, what was it ethical to do, or methodologically okay to do placebo control in this patient, in these kind of patients?
Yes, I mean they could have blinded if required.
The participants or the treating doctors, there is no possibility of them to have been blinded, because the intervention group would have been coming for more frequent visits, and they would have been getting more frequent titration of the medication doses. It would have been very practically difficult for an equivalent placebo tablet also to have been created and keep escalating. So practically, the participant and the treating physician could not have been blinded, but we felt that to the minimum, the outcome assessor who will be assessing the outcome, because that person should at least have been blinded.
Yeah, I mean, it's not that all RCTs can be completely blinded. Some, because of certain reasons, have to be non-blinded. Because creating a dummy like you were doing IV versus oral, to getting an equivalent IV dummy versus oral dummy to those patients, cost, feasibility, logistics, all those are actually not very easy.
Coming to the baseline characteristics, we want to see if the study groups are similar. So we can see that in the high intensity and the usual care arm, the age of the patients were around 62, 63. They were fairly well matched in terms of baseline characteristics. The percentage of patients with comorbidities like diabetes were 28 and 30% respectively. Patients who had coronary acute coronary syndrome or a CABG, patients who had a percutaneous coronary intervention were all fairly matched. Including patients who had a history of heart failure, they were all fairly matched between both groups.
There's no audio on Zoom.
Even if we look at the NYHA class of patients in both groups, 40 to 43% of patients in both groups were NYHA class 3, and left ventricular ejection fraction was less than 50% in majority of patients in both the groups, and they were hospitalized. 26% of patients in both groups were hospitalized for heart failure in the past year. So the baseline characteristics are fairly matched in both the groups. Sorry?
Journal of American College of Cardiology. JACC.
Okay. Normally, most of the RCTs these days, when they are publishing, they don't publish the total overall cohort outcome or p-value. They just put the comparator versus intervention arm. It's an observation.
Yes, obviously when they put the baseline characteristics, they ideally need to put the comparison. Maybe they have given the total.
Normally they are. Yes. Journal style system.
Coming to the study protocol, so we want to know here whether apart from the experimental intervention, did each study group receive the same level of care? So here the experimental intervention was rapid uptitration of neurohormonal blockade, which is the drugs beta blockers, ACE or ARBs or RBs or MRAs. We can see that so screening was done at visit 1, which is 24 to 48 hours after admission, and the randomization was done within 2 days before discharge. Subsequently, at discharge, the patients were optimized to half of the optimal doses, and they were followed up. The high intensity arm was followed up every weekly. So 1 week, and the second week, the drugs were optimized to full doses. Safety assessments were done subsequently at the 3rd week, 6th week, and visit 7 was 90 days from randomization. While the usual care arm was followed up as per their standard of care. They have not mentioned how frequently. So if we are to say whether there were any other factors that would have played a role in the outcome, the closer follow-up in the high intensity arm could have been a role, could have had an extra advantage to that arm, because apart from the gold titration, they could have got better counseling, they could have had more titration of diuretics as per the treating physician as compared to the usual care arm. So I would not say that they received the same level of care apart from the experimental intervention. This is a slide just on the optimal doses that they targeted of both the of all the medications. Now the safety assessments, they have mentioned that they have performed safety assessments at each visit. That was mainly to see whether there was any contraindication to uptitrating drugs like ACE, ARBs, if there was hyperkalemia or the blood pressure was too low, or if the patient's heart rate was less than 55, they would not uptitrate beta blockers. They also uptitrated diuretics if the NT-proBNP level had increased. So this was just a slide on the safety assessments that they looked at. So coming to the validity of the study population has been well defined. The outcomes have been clearly defined. Randomization and allocation concealment was done. Blinding was not done. Sample size calculation, it was powered for the primary outcome, which is 180-day heart failure, readmissions and death, but not for this. This is the secondary outcome. The intention to treat analysis, they have claimed to have done ITT, and baseline characteristics were well matched. So we can move on to the results of this study. They have done block randomization, stratified it for NBF and country.
Fixed block, variable block.
They have done variable block, 2, 4, 6.
One doubt, like usually we used to be taught that the sample size calculation should be for the primary outcome.
Yes.
Why have you mentioned that not powered for the secondary outcome?
So the primary outcome was 180-day heart failure readmission and death. But here they are looking at decongestion at day 90.
It was done before, no? For safety reasons, it was in reverse.
Coming to the results, so we want to know whether the results, the effects of intervention have been reported comprehensively and how precise was the estimate of the intervention. So these we'll look at the subsequent slides. First, a word on the statistical analysis. They have mentioned in detail the statistical methods that they have used, including for continuous variables, and they have also assessed the frequencies and categorical variables using chi-square tests. They have also done linear and Cox regression models and used SAS.
Why have they done log transforms and deep protein? On the same value.
So,
Why not they did? Why did they do
The log is skewed value.
Normally probability values are, one will have 10, 15, other will have 10,000, 18,000.
Yes,
So
yes, yes.
that does not make a difference. What's the cutoff for probability?
It is 500.
500, and some people will have 20,000 also.
Yeah,
Then it will be vastly distributed. So that's why for those values which have very wide distribution, they do either root, square, or any of the transformations. Or otherwise, they could not find the value, so they tried all the statistically, they try to fit in this one. I think last 2-3 weeks before, sir was saying, no, goodness of it, you fit it like this, fit like that, so that's why that thing.
So this was the sample size calculation. They have they required 1,800 patients to detect a difference in the event rate of 14% versus 20% for the primary outcome, and with a two-sided p-value of less than 0.05. Coming to the outcomes that they have looked here, comparing the high intensity care versus the usual care arm, and assessed at day 90 for clinical signs of successful decongestion.
Non-inferior treatment.
This is no, not non-inferiority. They are saying that high intensity is superior to usual.
Superior treatment.
So here they have taken N as 542 and 536 and assessed clinical signs of successful decongestion at day 90. So as we are already seeing, successful decongestion means a score of 0 in peripheral edema, JVP elevation and pulmonary crepitations. They have said 74.6% of patients in the high intensity arm had clinical signs of successful decongestion as compared to 62.7% in the usual care arm, with a significant p-value, and each of the components that contributed to that have also been significant, is what they have mentioned. However, when we did our calculation, this percentage was not found to be right. It was around 62% and 49% if we look, if it's a pure intention to treat analysis that's done, taking 542 and 536 as the denominators. So there was some discrepancy in the results that have been provided.
They
So-
could have subtracted the death and the 3 patients who were lost to follow. That
Yes.
is the denominator.
Yes,
So-
they have literally done, even if we do a per protocol analysis divided by that number, we don't get this particular percentage. So there has been some error in calculation somewhere.
How will it be published in the Act?
Yeah, it was good that David found that out just by looking at the percentages. He wanted to do it manually, but interestingly found that the percentages are actually not correct.
We also did a worst case scenario. If we look at the worst case scenario of 23 patients in the high intensity arm died and 5 discontinued, assuming that all of them had a bad outcome, and all the patients in the usual care arm, that is only the 3 people who discontinued, which we are unsure of, they had a good outcome. We try to calculate and see if the results would be the same.
They have taken the denominator, I think that 425 and 438 as their denominators, not 540 and this. But yeah, for ITT purpose, that
They
they
should
would
have-
not be the denominator.
Yeah.
Unless they are saying, okay, for safety purpose, we have completely excluded this has to be ITT. But that should have been mentioned in the when they were writing the results.
Yeah.
Like in the initial paragraph, is like, this many included, this many excluded.
Yeah.
They should have explicitly mentioned that. Like, for an RCT purpose, once you are randomized, if you're ITT, those are your denominator. They're not going to change no matter what. ITT or protocol, you can say yes, you can change it.
If you do the worst case scenario, the high intensity arm will have 310 favorable outcomes, while the usual care arm will have 270 favorable outcomes. Doing a calculation, we can see that the odds ratio would be 1.3 with the lower limit of 1.03. So closer to 1 may not have a significant difference between both arms.
Even would still come significant. For
Yeah.
the
These were the other results in terms of decrease in weight in both arms at day 90. There was more decrease in weight in the high intensity arm than the usual care arm. And coming to NT-proBNP values also were lesser in the high intensity arm than the usual care arm. They have also taken another calculation among patients who achieved successful decongestion at pre-randomization, that is during their hospital stay, and compared at day 90 in the two arms, high intensity and usual care, and found that among both patients, one cohort was patients who achieved successful decongestion at pre-randomization, the other one was patients who did not achieve successful decongestion at pre-randomization. And looking at day 90, they have found that the high intensity arm had more people who had clinical signs of decongestion, irrespective of whether they achieved decongestion at pre-randomization or not. They have also done a multivariable analysis to look at the odds ratio for congestion scores, and they have found that in terms of congestion scores, high intensity had a better odds ratio. But in the multivariable analysis, they have not taken all the univariate analysis that were significant. For example, diabetes, history of atrial fibrillation, all these have not been accounted for in their multivariable analysis.
Normally, what would you suggest for the multivariable analysis?
They should take all the significant univariate and do the multivariate analysis.
I think sometimes in the analysis they will take all the variables even if it is not significant or like something you think very clinically significant, even if it's not coming, you might put it. Or some people may say, okay, less than 0.05 in the multivariable, so you take a double the cutoff or quadruple the cutoff, less than 0.1. All the factors which will come reasonably significant, they will put in the multivariable. That's what most people do. I don't know how it is. Which is random, which one. It seems that even the significant ones are not carried over to the multivariable. That is really what really.
They have also done a time-dependent covariate, calculating the hazard ratios for this is the primary outcome, 180-day heart failure, readmission or death, and found it to be lesser in the high-intensity group. Coming to the benefits of the experimental intervention outweigh the harms and costs. So we just look at the adverse events and the approximate cost if we were to implement it in our OPD setting. So for the optimal dose, that is the maximal dose of spironolactone, enalapril and metoprolol, will come to around 232 per day. That will come to around 6,900 for medications alone, including, let's assume the patients we call them monthly for an OPD visit, including travel, OPD, test, approximately will come to 8,225. But this is excluding the loss of wages for that day particularly. Coming to adverse events was 41% in the high intensity group, but only 29% in the usual care arm. So there was a difference of 12% in that. If you look at the absolute risk reduction, it was around 12, and the number needed to treat will come to around 8.3, which is 9. The number needed to harm, which is also 100 by the 41 minus 21, is also around 9. And the cost of treating 9 patients for a month will come to around 74,000. So if we spend 74,000, one person may benefit, one person may have harm as well. So will the results help locally? For this, we looked at the baseline characteristics of what they have looked at and whether they compare to our population. Looking at the total baseline, the age was around 63, and diabetes, one thing I found a bit less was diabetes, only 29%. It would be more in our population. While these could compare to our population, patients who present in NYJ 2-3 to our OPD or LVEF less than 50, that could be comparable. Limitations was that it, as we've already discussed, it's an open label study. There have been few problems in methodology. There has been a differential follow-up in both arms. They have kept relatively strict inclusion and exclusion criteria in terms of NT-proBNP levels and prior medications. SGLT2 inhibitors have not been given to either group, but now it is essential. Will it provide greater value to the people in our care? Apart from, so if we were to implement it, we have already seen the costs and closer follow-up. Coming to our primary question, in this 50-year-old male who has comorbidities, previously admitted for heart failure with a reduced ejection fraction, would we rapidly uptitrate neurohormonal blockade to achieve significant decongestion? As per this study, we would not, but it's open to interpretation.
Thank you, David.